So hello, everyone. Welcome to today's Distinguished Researcher webinar. We first of all want to thank all of you for participating and to thank our presenters for taking the time to be a part of the series. Today we are welcoming Dr. James Boswell and Dr. Gayle Brooks. Dr. Boswell is an associate professor and director of clinical training in clinical psychology at the University at Albany and a fellow of the APA. He is a past president of the North American Society for Psychotherapy Research and an associate of the Center for the Elimination of Health Disparities. His research focuses on process and outcomes of psychological interventions, as well as the integration of science and practice, including measurement-based care. Dr. Boswell's work has been funded by agencies and has directly influenced national standards and guidelines, including the Joint Commission Standard for Behavioral Health Outcome Monitoring and the APA Professional Practice Guideline. He serves on 9 editorial boards and contributed as a technical expert panelist on the government-sponsored white paper prepared for the U.S. Department of Health and Human Services and the Office of the Assistant Secretary for Planning and Evaluation on strategies for measuring the quality of psychotherapy, and has received multiple prestigious awards for his scientific contributions, including early career and mid-career recognitions from SPR and APA divisions. And Dr. Brooks is Vice President and Chief Clinical Officer for the Renview Center. Dr. Brooks is member of the Renview executive team, and she oversees the Renview clinical training and research departments. For the past 30 years, she has treated patients from diverse backgrounds who suffer from eating disorders. Dr. Brooks served as the eating disorder specialist since the HBO film Thin, has appeared on Good Morning America. She has been featured in the following publications: the New York Times, People Magazine, Essence Magazine, and Perspectives, and the Renview Center Foundation's Journal for Professionals. Dr. Brooks is co-author of the Renview Unified Treatment for Eating Disorders and Comorbidity, an adaptation of the Unified Protocol. A frequent presenter at conferences and workshops, Dr. Brooks speaks on topics such as the treatment of the complex patient, eating disorders and cultural diversity, the interplay between eating disorders and trauma, and eating disorders in midlife women. Thank you again so much for being here today. I will just mention to our participants that you have a new function that hasn't been introduced into webinars before. I will just bring your attention to the bar at the bottom of the screen. You have the option to click show captions, and then you will have the option to have the webinar translated live to whichever language you're comfortable with. So just know that you have that option. And I will also mention that the questions today will be addressed at the end of the discussion. So thank you again and enjoy, everyone.
So I'll dive right in. Thank you for that introduction. We appreciate it. And so, hello, everyone. We're honored to speak with you today and share our story about an ongoing and long-term collaboration between some academics and a large real-world practice context. So specifically, an ongoing attempt to realize science practice integration and a US-based network of intensive eating disorder treatment clinics. And so you probably noticed the title that we messed around and created a learning health system. So obviously we'll be talking about learning health systems and walking through what we think is probably a good example of a contemporary version of this. In saying that we messed around in the process, that's intended to be tongue-in-cheek. I would like to think that we were a bit more purposeful. You'll see as we walk through some of the history of the collaborative effort that it really was informed by evidence both from clinical science, but then also implementation science. And it's been this mutually reinforcing process with some good, bad, ugly aspects and some setbacks and some successes. And we're really excited to talk about the effort with you today. So before we dive in, though, maybe do some introductions. So I can start. So I'm James Boswell. Maybe I don't need to spend so much time because we were just introduced. but as most of you may know, I'm a psychotherapy process researcher. I've been a member of SPR for many years. I'm particularly interested in practice-oriented research, which we will discuss extensively today. And I've been very fortunate to collaborate with Dr. Brooks in the Renfrew Center for about a dozen years now, taking on different roles in the process. And I don't have any conflicts to report. So, Gayle.
Yes, hi all, everyone. I'm Gayle Brooks, and I'm the Vice President and Chief Clinical Officer at the Renfrew Center. I've been with Renfrew for over about 35 years now, so it truly is sort of my home and my family, and been in the field of eating disorders for that whole time. My role, I sort of oversee the quality of clinical care across our sites, and also I am overseeing our training department and our research department as well. I also have no conflicts to report. I will be touching on the Renfrew unified treatment for eating disorders and comorbidities, which is a manual and a patient guide, but I get no royalties from that.
All right, thanks, Gayle. So moving right along, here's a brief outline of what we'll cover in the webinar. So hopefully we'll have plenty of time for discussion at the end. But I want to start with some key definitions to set the context. And I apologize ahead of time that some of this initial content may be a little dry because you may be familiar with this, but I do think it's important to kind of set the table as we get into more complex real world issues. And so we'll start with just a basic review of what we mean by evidence-based practice and practice-based evidence. We'll connect those two features while we talk about practice-oriented research and what that typically entails. And then we'll describe learning health systems and what the commonly defining features tend to be. And then we'll get into really what is the primary focus of the presentation, which is introducing the Renfrew Center, starting with its context and history, and then walking through the work that's been done for the last 15, 20 plus years as what we would see as a developmental kind of case study in a learning health system build. And so we'll be chronicling some of the activities and accomplishments of that work. And so before we sort of open things up for discussion, we'll also end by talking about kind of higher level future directions and some lessons learned. Okay, so now for the dry stuff, you can maybe put me on mute and answer emails or something now. But so most people may be familiar with APA's definition of evidence-based practice. And so it states that evidence-based practice is the integration of the best available research with clinical expertise in the context of client characteristics, culture, and preferences. So even though APA doesn't adopt the three-legged stool metaphor explicitly, the one that's commonly used in medicine, the idea is that you have research evidence as one leg of the overall stool, and that clinical expertise and responsiveness are respective other legs. Now, historically, and this has been a matter of discussion, over the years, evidence-based practice is sometimes conflated with evidence-based treatments or empirically supported treatments. And within this definition, as many have pointed out, that component, that evidence-based treatment or say an empirically supported treatment protocol would really only be one leg of the overall stool. And so it's important to have some shared agreement on this point because it really does underscore how evidence-based practice isn't something that you simply pluck off the shelf and then deliver it to a client and you call that evidence-based practice. That evidence-based practice is by definition an integrative process. And so you'll see as we talk about the defining features of a learning health system that it's a really excellent example of representing scaling up that evidence-based practice process. And also just to note that one issue with the three-legged stool metaphor is that while part of the same stool, we think about research evidence as a separate leg and again, often tied to treatments. But obviously in psychotherapy, we're very interested in generating evidence on participant characteristics that may be associated with response. And so it's not just what works, but what works for whom. And so you'll see in this presentation that the research that's been done isn't just focused on the effectiveness question. Renfrew's also been very interested in understanding predictors, moderators, contextual factors that might help them understand responses in their site. And so, whereas evidence-based practice is going to historically privilege researchers as the primary producers of evidence, which of course could include all the different types of evidence I just mentioned. Practice-based evidence privileges engaged psychotherapy stakeholders as viable producers of evidence across ecologically valid contexts. So in the clinical setting, with clinicians who are actually in that setting, they're not just consuming the evidence that exists, they're also generating local knowledge that's going to help them with their own patients, as well as improve services, and provide valuable information to the field that can be disseminated in webinars like this, in journal articles, et cetera. And so practice-based evidence as its own sort of concept isn't new. Many of us are probably familiar with practice research networks, which in mental health research has been defined often as kind of non-hierarchical collaborations between academics and clinician or clinical stakeholders. And so many, many decades ago, practice-based research networks were sprouting up in private primary care practices across different countries. And importantly, those particular initiatives were clinician-led. So similar in spirit to George Stryker's description of the local clinical scientist, these were groups of clinicians agreeing to systematically study their own patient populations and treatments and share those observations with like-minded colleagues. So because these efforts prioritize local knowledge and ecological validity, they rarely involved experimental methods, and at least not beyond what would be considered a single case design. So perhaps because of this, historically, practice-based evidence has been largely viewed as kind of second-class evidence in mainstream academic circles. And so I bring this up not because I believe that experiments or randomization, et cetera, that's irrelevant, that those things are very important. But I do believe that the dynamic nature of routine practice is unique in a way that doesn't ultimately always map onto these group level observations and comparative effectiveness studies. And that local data is almost by definition always going to have the fast track to clinical relevance and timely responsiveness. And so I bring this up in part because we don't want to lose the fact that this whole effort that we're talking about today was spearheaded by a clinical setting. It wasn't spearheaded by a bunch of researchers. Okay. So to that end, practice-oriented research is concerned with improving, understanding psychological services as they're implemented in the routine. So this type of research can include learning from existing practice-based data. So we're not actually messing with anything. We're just going to try to understand the information we have. But it could also involve implementing novel structures or procedures to generate new practice-based evidence. So Castonguay and colleagues delineated 3 common features of practice-based evidence in the context of practice-oriented research. These include data being collected as part of the routine practice. What is assessed is also reflective of routine practice, and that any investigation involves minimal, if any, constraints on the nature of routine practice. So just to say a little bit about this last point. So again, almost by definition, that if routine practice is changed in any way to accommodate research procedures, then the generated information is technically not based on the pre-existing routine because you've changed something. But when you consider the broad definition or the ultimate goals of practice-oriented research, we have to accept at some level that there will be changes. So just as an example, if I collected routine data in my setting on social determinants of health and found that, as one might expect, individuals who endorse a lack of reliable transportation to healthcare appointments are also those individuals who are more likely to no-show or drop out of treatment. And so I might brainstorm with my colleagues strategies for improving transportation or increasing parking accessibility, et cetera. And then we implement those changes in our setting and we continue to track social determinant and retention rates. We hope that retention improves. But in this particular example, we did use local data to then intervene in a way that was different from the status quo. But while it was a change in existing practices, this very much is consistent with the spirit of practice-oriented research. All right, we're almost done with definitions. Okay, so if we consider the practice-oriented research paradigm that centers practice-based evidence, learning health systems, I will argue, provide an excellent structure for implementing this paradigm and a set of processes that support continuous practice-oriented research and practice-based evidence generation. So specifically, in a learning health system, internally collected data and experiences are systematically integrated with external evidence, and that knowledge is then put into practice in the system, as well as disseminated to relevant people like us. So external evidence of the variety that's often connected with evidence-based practice and internally generated evidence of the variety that's often connected with practice-based evidence are mutually reinforcing streams. And consistent with the definition of evidence-based practice, the stool legs related to clinical observation and contextual factors are also hopefully part of that systematic investigation. And so the U.S. Agency for Health Research and Quality, or AHRQ, years ago outlined 5 key features. If you go back to the website, they actually outlined 6 features, but if you read them carefully, 2 of them seem identical to me, so we're going to go with 5 for this presentation. But 5 features that define a learning health system. And as we go through these and as we talk today, I think it is important to emphasize that we really are talking about a system level focus here, that we're talking about bigger networks, hospital settings, systems of clinics, et cetera, rather than necessarily solo practitioners. And so the defining features, at least AHRQ would argue, are that learning health systems have leaders who are committed to a culture of continuous learning and improvement. They systematically gather, analyze, and apply evidence to improve care. They employ IT methods to share new evidence with clinicians to improve decision-making, hopefully in a timely way. And they promote the inclusion of patients and clinicians as members of the learning team. Finally, they also continually assess outcomes to refine processes and training to create a feedback cycle for learning and improvement. So one can see right away that we're talking about an integrative process. So this is dynamic. This is not a static activity. And we probably have noticed too that this shares a lot of overlapping features with the work that's being done in measurement-based care implementation, which is not a fluke, just given how important the data collection part is to this. And so with that introduction of terms and approaches, I'm going to now hand things off to Dr. Brooks, and we'll begin to walk through the work that's been specifically done within the Renfrew Center, and then come back to our definition of a learning health system and kind of walk through whether or not this actually is a good example of one. Yeah.
All righty. So actually, it's my pleasure to be able to sort of join with James and tell our story, because it truly is, I think, a 10 to 15-year labor of love that had its ups and downs, but it's been just so crucial, I think, to the work that we do at the Renfrew Center. For those of you that are not familiar with us, we are a national treatment network, facilities that treat eating disorders, among other things. We primarily treat eating disorders, but certainly see a lot of comorbidity as well. James, you want to go to the next slide? We have, a large network of facilities. We have 2 residential facilities where we provide 24-hour care with nursing and multidisciplinary teams. One is in Philadelphia, the other is down in Coconut Creek, Florida, where I'm located. We then also have 13 what we call non-residential facilities, and these are sites that provide day programming as well as IOP programming. And they are in multiple states across mainly kind of centered, as you see there, in the Northeast. We have a few in the Southeast as well. And within the last couple of years, we have now also developed 2 virtual sites, one in the Northeast and one in the Southeast. And we'll be touching a little bit on that evolution that's happened for us as well. So, James. We provide a continuum of care everywhere from our very acute residential, which I mentioned was in the 2 sites in Philly and Florida. And we can accept patients who are pretty critically ill as long as they don't need to be on, IVs and that sort of thing. We can handle them within our sites. Then we have the step down of PHP, or day programming. Each of the levels of care provide sort of increasing levels of structure to help with symptoms and also to deal with a lot of the medical and psychiatric complications. We have IOP, which is an intense outpatient program. It's more than outpatient, but it certainly, isn't a day program. And it's typically in the evenings and runs about 9 hours a week, 3 days over a 3-day period. We do some limited outpatient services, mainly groups and things. And what's important to know is just that our patients kind of move up and down our continuum of care. And that's pretty typical for patients with serious eating disorders, is that they need varying levels of structure and intervention depending on the seriousness of their eating disorder. We also have multidisciplinary teams. I won't go through all of this here, but as you can see, we have a lot of different disciplines that are involved. It really does take quite a few different specialists to be able to treat eating disorders. And we function in a team model. Our teams are led by psychologists. However, we do have other, the psychiatrists and nurse practitioners and physicians are on our teams as well. So let me just tell you a little bit about how we started. The Renfrew Center started in 1985, and we were actually the first residential treatment facility for eating disorders. Now there's a whole lot of them, but at the time we were the first. And when we opened, there really wasn't a lot of research in the area of eating disorders. There really wasn't much to look at in terms of, what is the most effective way to treat eating disorders. And so, and this was particularly true for higher levels of care. There really was nothing. What we needed to do at that time was really look outside the field of eating disorders and see what is some of the evidence-based work that was being done, particularly around gender-specific treatment, because at that time, the belief was that eating disorders are primarily disorders of women. And that's what the patient population was that we were treating. Since then, the field has evolved, and we understand that it is not necessarily gender specific. But that really became the sort of focus of the treatment model that we were looking at. And so we started really focusing in on the work that was being done at the Stone Center on the psychology of women and how they heal most effectively within the context of empowering, growth-enhancing kinds of relationships, and viewing the eating disorder as being a relationship that the patient has with their food and their emotions that is not serving them well, and that oftentimes it's due to relational traumas that they've had in their life, and treatment really addressed those sorts of things. So that's very much our beginnings in terms of our treatment model. James. So for many years, I would say probably for the first 15 or so years, 15, 20 years, we really felt like we were being pretty effective with our patients. Patients were telling us we were being pretty effective with them. We thought we were doing a pretty good job. But one of the things that was happening is that the field of eating disorders was evolving, and there was much more research that was coming out to show that certain things work better than other things, and that we were starting to get, called to task around, are you using those interventions, and are you able to show that those interventions are effective for you? Some of you may be aware of an article that came out in the New York Times in 2016. It was written by several actually researchers at some of the major hospitals that were really looking at eating disorders, and they began to look at the treatment facilities that were out there, the residential facilities that were proliferating across the country, and began to question, what kind of treatment is happening here? Is this effective treatment? Can you show that it's effective treatment? How are you, training your staff, and all of those sorts of things? And these were important questions to be asked, because residential treatment, as well as other higher levels of care, is expensive. It costs a lot, and I think it takes a lot out of a person's time to be in these facilities. And so we needed to show that what we were doing was effective. But what we experienced, and I think many of the treatment facilities experienced, is that implementing evidence-based treatment is not easy. Because these are such complicated, complex treatment environments, you can't just slam dunk something in there and think it's going to work. So even if we wanted to do it, it was not going to be an easy lift for us. But nonetheless, we really didn't have a choice. Insurance companies, licensing boards, consumers even, and researchers were all calling for us to really provide more evidence-based care and more outcome research that showed the work that we were doing was effective. Okay. So there was a stab at it initially for us. Michael Lowe, who some of you may be familiar with, he's a well-known researcher at Drexel University, had somewhat of a long-standing relationship with us at Renfrew. He sort of started, I think he'd been with us well over 10 years before we even started down this process. And he was helping us to just, with our very rudimentary research department, help us to start to collect data, sort of what kinds of assessments should we be using, how were we sort of analyzing the data and that sort of thing. But it was just very rudimentary in many ways. But one of the important roles that Michael had at the time, because I was very involved with him, was that he was whispering in my ear about evidence-based treatment and saying, Gayle, you guys really need to look at this. And of course, not knowing what I don't know, at the time, I was sort of saying, well, we're doing good work. Look, our patients say we're doing good work. Our therapists think they're doing good work. We're doing good work. And he said, well, but you know what? You don't really have the evidence to sort of show that. So he got a NIMH grant that he asked to be able to then do a study at 2 of our non-res sites in the Philadelphia area, really implementing normalized eating CBT, a CBT approach. He'd asked me whether we use CBT, and my response was, well, I think we do kind of CBT-ish, which was that I think people knew what CBT was and maybe tried to do it, but we certainly weren't doing it in an evidence-based fashion. So he came in to do this study, and I remember at the time just sort of thinking, good luck. I really wasn't sure how this was going to go. And to cut to the chase, it did not go particularly well. The clinicians at the sites had a very strong reaction to this researcher coming in and saying, okay, here's the protocol that we want you to do. And I think they felt like somehow they were being told that the work that they were doing was not up to par or was not quality. And they had a lot of really strong reactions to that. And they probably felt at the time that they were doing normalized eating, that was because we would often talk about normalizing eating, but I don't think they really understood what manualized care of normalized eating really entailed, and really saw it as being very rigid, very narrow. And a lot of what they felt is our patients are coming in very complex, they have a lot of issues, and we want to relationally connect with them and kind of ride the wave with them and not necessarily have a manual that's telling us what to do. So it wasn't for not trying. I think Michael and his group tried very diligently to sort of have this intervention get implemented. But ultimately, it did not yield the intended results, is I think the kind way to say it in this way. But Michael did write a paper that really talked about how difficult it was to do this. Okay.
Yeah. So I'll take the baton based on that, because I think you should see when that work was done in the early 2000s, is that one issue is that there wasn't the benefit of some of the implementation science work and focus that we've seen in recent years in mental health. And so, I had mentioned before that it's important to think broadly about what counts as relevant external evidence to integrate into practice. And so, evidence from implementation science, not just clinical science broadly, but implementation science is a good example of that. And I would argue, based on our experience, that it's quite necessary for a sustainable learning health system. Because implementation science, for those who don't know, is the scientific study of methods to promote the uptake of research findings and evidence-based practices in routine care. And so there are frameworks and guiding principles that exist that can help inform the uptake of external evidence, but then also support trying to harness internally collected information. So sort of coming into the picture a bit later after the study that Gayle just mentioned, that I've always, had an interest in science practice integration and issues of fidelity and sort of the nuance around that. And when I was in graduate school, because of that interest, also it related to my interest in reaching outcome monitoring. I was finding myself starting to read quite a bit of the industrial organizational psychology and applied medicine journals. And it was just somewhat dumb luck that I came across Fixon and colleagues' implementation research synthesis and some of the diffusion of innovation work by Rogers and Greenhall and those writers. And so as I was reading those things, I was really thinking about them more, or sort of seeing them through the lens of a process researcher. It wasn't until implementation science, it didn't really start to click to me until I was really on my postdoc at Boston University. And so the timing was really fortuitous for this Renfrew project to kind of fall in my lap, so to speak, because I was kind of ready. I was familiar with the literature and could understand, without really knowing all the context, the things that maybe made the previous effort not work as well. So primed to apply some of these frameworks and strategies to a new problem. And so we very much entered into this collaboration, which we'll say more about, with this phase model in mind that Fixon introduced and others, as well as context from the CFR to really guide both our formal and informal evaluation plan in the early stages. We were also guided by Proctor's implementation outcome scheme. For example, and I'm talking not just as kind of the researcher consultant person, but as a team, that we needed to be objective and decide, like, is this model appropriate for this context and population? That was an open question. And if it is, at least on paper, really think carefully about the feasibility of overhauling the treatment model, and is it feasible to train everybody who needs to be trained? And in the early phases of adoption and initial implementation, really thinking ahead to how things like fidelity would be assessed. And if we found out early on that there were issues with fidelity, how do we address those problems? And so if we really want to simplify it, we wanted to go into this anticipating, but not immediately dictating the process to the clinical stakeholders, very much in the spirit of a PRN. Yeah.
Sure. So as we started to sort of grapple with this whole notion of us needing to really look at our treatment model and figure out if, well, not even if, because we really needed to infuse an evidence-based treatment, but starting with the why would we be doing this? What's important about it? And there were some specific goals that, that were really important to me, that I really sort of had us spend a lot of time with, which was that if we're going to really be putting ourselves out there as a treatment facility that has high quality care, and that you can see it across our whole organization, that we need to then be able to have a model that is understandable and is actually producing results that support that the quality is there, and that we need to be looking at best practices. We're still somewhat of a fledgling field, and there still wasn't a lot out there about residential care in particular. But we needed to know that, we were at least implementing the best practices of what was known. And the fact that we were big. I mean, we have 350 some professional staff across our organization, and it needed to be standardized. And it's like herding cats sometimes, trying to get everybody up to competency and fidelity, doing what you want them to be doing. So the task seemed at the time pretty overwhelming. There were a couple of things we put in place to try to sort of really focus on infrastructure, because it was going to be important that we move beyond being siloed in our various sites to really having some structure that could support us, support our standardization goals. So we established a clinical excellence board, which was made up of our clinical leadership at our sites, and also our administrators and the important stakeholders there. And we also had an advisory board where we brought in consultants in both the research and clinical practice realm to be able to consult with us, give us guidance, and more importantly, give us feedback about sort of how we are doing. We developed a training department because it became very clear that training was going to be at the heart of all of this, that we needed to be able to roll out standardized training across the multiple sites. I think initially I thought it was going to be a lot easier. You just develop a few PowerPoints, go out there and teach them what to do, and it should be fine. you'll learn that I learned a lot, that was really not how this works. But we knew we were going to need to have the resources. We also needed to expand our research department. I told you we had a sort of fledgling one at the beginning that was just really collecting data, but we weren't really doing much with the data. We weren't getting really good responses necessarily in terms of clean data sets and that sort of thing. So we really had to strengthen that infrastructure, which we did as well. So as I looked at with some of the, some of what our Clinical Excellence Board was sort of grappling with is, we know we need to start to implement and expand our treatment model to include evidence-based treatment. But what we're faced with are these multiple layers of complexity that we're dealing with. And it was making it difficult to sort of figure out what was going to be the best path for us, because whatever it is we implemented, it needed to be able to be, effective at all levels of care that we have, that it needed to be scalable up and down, that it needed to be something that was appropriate for all of our sites and easy enough for me to train, that we could train across all of our sites, and that all disciplines could learn it. That it wasn't just, we weren't just focusing on our therapists, we were focusing on, psychiatrists, nutrition, medical doctors, even our admissions department, because we needed everyone speaking the same language and understanding the model in order to be able to have it be effective. And our patient population at that time was very complex. Now it is incredibly complex, which is continuing to sort of have some ramifications for our model. But that whatever treatment we put in place, that it can't just be focused on the eating disorder, because eating disorders, rarely travel alone. We're dealing with PTSD and, depression, mood disorders, the whole thing. And so we needed a model that would address that. And so we started looking at the various evidence-based treatments that showed promise. And we reviewed a lot of the research that was out there in our clinical excellence board, and got some feedback from our clinicians and from our outside consultants. And the thing I had that I found myself thinking is, this is hard and somebody must have already done this. We can't be the first place that is trying to figure out how do you address all this complexity. Next slide. So as it happened, I came across an article that was written by David Barlow on the unified protocol. And some of this all kind of lines up to me serendipitously, that how it all kind of came together, because there was certainly no thought on my part that there was a specific direction to go. But I read this article that that Dr. Barlow had written on the unified protocol. And as I read it, he was sort of speaking my language, which was that, we really needed to have an approach to emotion disorders that are more principle-based rather than, just sort of slices of evidence-based approaches for various types of symptoms, but really looking at more the underlying mechanisms that were driving symptom use. And this just seemed to make a lot of sense to me. And the more we started to look into it, we felt like it really fit our culture well. Our treatment model was already very emotion focused, and this is, the UP was an emotion focused, CBT emotion focused approach. And because it was principle based versus, really looking at specific symptom pictures and that sort of thing, it wasn't overly complex. It was something that, it was understandable. I felt like, we could really be able to train our staff. And because it was sort of based on a lot of the principles that were found to be effective across evidence-based treatments, it was more something that our staff felt could make sense to them, because many of them might know some DBT, some may know some ACT, that sort of thing, but it all sort of made sense to them in this sort of more transdiagnostic approach. And it seemed to be something that we could scale up and down across our various levels of care. we needed it to be stage approach, have a staged approach, because our patients come in at various times and in various levels of disorder and distress. And so they needed to be able to work their way through the model. And it just needed to be coherent so that, we could coordinate it across all of our therapists and disciplines. And so the unified protocol is what we ended up going with. So as I mentioned, sort of the serendipitous part of all of this, once I got very interested in the UP, as it just so happened, David Barlow was going to be the keynote speaker at the International Conference on Eating Disorders, the Academy of Eating Disorders. And he was going to be speaking on this very thing that year. And Michael Lowe, who I mentioned to you before, he actually knew David. And so when I reached out to Michael and said, do you think this is something we should go, see him? And he goes, oh yeah, let's go, because I know him and we can kind of connect with him. So we went to the conference. Dr. Barlow gave a wonderful talk. And again, I felt he was speaking our language. He was kind enough to meet with a small group of us from Renfrew, and along with Michael Lowe, who made the introduction for us. And in some ways, it feels to me like the rest was history. He was very open to working with us. He felt like what we were looking for, the UP would really fit with, and he got us connected with his colleagues that he felt would be the ones that could really be in the trenches with us and help us sort of move this forward. And that happened to be Heather Thompson-Brenner, who was at the time at Boston University, and also James was the other individual that he connected us with. And we went from there. It became a collaboration that unfolded over time. Oh, you're on mute, James.
Sorry, I have loading dock noise. Sorry. I don't know if I've ever said this to you, Gayle, but I was very intimidated by this task. I mean, at the time, I just assumed the role of director of education and training for the UP, and so I was kind of the obvious point person for it. But as I mentioned, like I was very interested in the topic and was kind of excited to start to apply some of what I was learning and some of the other research we had done to this new setting, because I'm not an eating disorder researcher by training by any means, but I was also, I felt relatively comfortable, in the sense that like I had a really, maybe the best possible role model for the type of work, because when I was in grad school working with Louis Castonguay, I watched him build, expand, and sustain multiple practice research networks, and really saw how he skillfully would facilitate these genuine collaborations with colleagues with varying professional roles and interests, and being able to kind of navigate being flexible, but also not straying from a solid empirical foundation. If there was a clear, like, this is the best way to do it, and we should do it this way, like you want to make that argument too when it's most appropriate. And I don't know if anybody's knows Christopher Guest's movies, like Waiting for Guffman and Best in Show, and the people, they're all involved in Spinal Tap in various movies. And in Waiting for Guffman, which might be my favorite Christopher Guest film, Eugene Levy is I believe a dentist who gets pulled into doing community theater. And it's this mockumentary style movie. And so they're interviewing Eugene Levy, who's in this local play. And he's talking to the camera and he says, people always say, you must have been the class clown. And he stops for a second and says, I say, no, I wasn't. But I sat beside the class clown and I studied him and I saw some things and I saw how to make people laugh. And so that's the way I can think about it. It's like, no, I'm not the expert, but I sat next to the expert and I watched it and I picked up some things.
Well, sitting next to me, you were the expert, so it was you hit it well. So one of the things that I think was really important in this whole process was looking at how we were going to have it, in some ways, to me, be Renfrewized. How was it going to be able to be adapted to work within our treatment facilities, within the within eating disorders more specifically, because the UP is transdiagnostic and it's not necessarily hanging on eating disorders. And I don't know that a lot even had been done with eating disorders up until that point. But I think once it became clear to us and understanding that, eating disorders are emotional disorders as well, and that is the sort of through thread that can have our work using the UP with eating disorders in a specific way that can be helpful. So we did go through a process of adaptation. I think the openness with the UP team in kind of adapting to what sort of our needs were. Part of the adaptations that needed to occur were being able to put language around some of the interventions that was somewhat anchored in eating disorder symptomatology, so that, because we really had to make that link that eating disorders are emotional disorders, and we need to look at then what fuels, emotional disorders. So a lot of time and energy was put into that. The other thing is that the unified protocol doesn't really have strong direction around relational principles and sort of the relational part of it. And that still is very much at the core of our treatment and our treatment model and how we deal with patients. So we wanted to really infuse some relational principles into, and cultural principles as well, into the treatment. And so that's what then ended up with us having the unified treatment model, which is an adaptation of the UP. There were a lot of preliminary steps that we did before we even got started. And this was one of the ways that I think both James and Heather Thompson-Brenner were very helpful to us, was to kind of give us some guidance on steps that we needed to take before we even did this. And one of the things that happened was that Heather, as a clinician, she came and actually embedded herself in our programming for a couple of weeks, in both of our residential facilities, just to learn what we do. Before we change any of it, it was to kind of know what we do. That was very, very helpful, because she could then give us feedback on what are some of the things that we do, that we were doing, that were somewhat consistent with the model that we're looking at, and sort of more in an evidence-based way, and what were some of the things that we were going to probably have to let go of because it was not necessarily consistent. But she really got very much involved with our staff. They also had us survey our staff around evidence-based treatments before we even got started, so that we had a sense of what we were up against, whether, people were going to pretty much go along with it, or whether we would see a repeat of, some of Michael's experience. And so we did do a survey, we did some focus groups with our staff, and as you can imagine, there was apprehension, a lot of apprehension. We looked at who seemed to be most apprehensive, and some of it, was different depending on disciplines. Psychologists tended to be more open and whatever. Some of our master's level therapists a little bit more suspicious about it, and our creative arts therapists just thought it was going to destroy what we did. So, and psychiatrists were kind of like not sure that it was going to make all that much of a difference. So we had a sense of what we were going to need to be doing. It also allowed us to be able to go back to it after we implemented, to sort of see, did that change? And then we started developing a training plan to be able to train all disciplines. That was really important to us. We weren't just focusing on therapists. And to develop protocols for all levels of care. And as you can imagine, even though it's the same model, it needed to have some differences in terms of how it was presented. There wasn't as many hours of treatment in lower levels of care than higher levels of care. This resulted in us creating the therapist manual and patient handbook, and that eventually was published. And we also had to, because we are very group focused, our patients are in 7 to 8 groups a day, so 80 some groups in a week for residential. We needed to kind of reformat that. And so I gave the directive to our program managers to do a practice of throwing out everything and saying, if we were to start over, what would it look like? And we came up with a group schedule that very much made the UT concepts primary, but also had room for some of the other groups that clinicians felt were important for patients as well. then we had to really work on trying to get everybody on board, which wasn't easy and truly was a campaign for the hearts and minds of our staff. And we knew it was going to be tough, but we also knew that we had to really increase their desire to want to have things change, because I think there was a real pull to kind of stay with what everybody knew. So we identified some internal champions. Certainly the training department were internal champions, but I also went after the leadership in each of our sites, the site director, the team leaders and whatnot, because I knew that they needed to be the ones to to really have the excitement around it in order to get their staffs on board, and that they were ultimately going to be responsible for supervision and making sure that things stayed in place over time. So we identified internal champions. I also had to do some selling of our administration. We were, uh, you know, Renfrew was very much identified with relational cultural theory and feminist psychology. That's very much at the core of what we were. And they were very concerned that we were going to bring in this mechanized treatment that patients weren't going to like. And ultimately, our revenues would drop off because people wouldn't want to come into treatment. That was somewhat of their fear. Fortunately, I think I'd been with Renfrew long enough that our owner sort of trusted us to go in this direction. We also had James and Heather come and speak with them about the benefits of it. And, so everybody sort of sold it and we were able to go. We also used a lot of the UT principles with staff, that a big part of the CBT approach is leaning into discomfort, leaning into, anxiety, and using various strategies to be able to, somehow tolerate that, open your window of tolerance. And we use that with staff to help them to be able to, deal with their own anxiety. And we also got some work groups together that could collaborate with various disciplines to be able to learn the model. Training was and has continued to be at the heart of what we do. When you have as many clinicians and practitioners as we do, people are always coming and going, and you are always training people. And what I learned very early on is that there is a big pull towards treatment as usual, and that we needed to make sure that we were keeping our staffs well trained and looking at competency and fidelity. So how we started with the training is that we made sure that the training department knew the UP really well. So we got them certified to competency, and James was very involved in that with us and assessing their competency as trainers. Then we started training our clinical staff. They received 16 to 28 hours of training in person. And we went to every site to roll it out. And we also, James taught us a lot about assessing competency and adherence. These were all sort of new concepts to me. And so he helped us develop some materials for assessing a competency. And then we also learned, how to be able to know if a person is, if a clinician is doing what they've been trained to do. So we had to get some equipment together to get them to record their groups, which James's lab then rated for us and letting us know whether we were meeting competency or not, and fidelity to the model. And we also integrated technology in other ways, just in terms of how we presented material to patients, because patients in treatment really need to be engaged in the material, and this CBT material isn't always all that engaging. So we have used a lot with media and other types of creative interventions to help them to understand the material and to work on the material. And then we continue to recruit expert champions in various areas that were training. And so we trained other staff up to competency, and then they were involved in training others. And that has continued to be our model going forward. So needless to say, it was a bit of a rocky road. one of the things I learned very early on was that implementation science was a thing. I didn't know it at the time, that there could be a way of doing it that could possibly make it more successful. And so it was good that we sort of had that going forward. What we found was that staff could have very strong reactions to change. And, whereas initially when we looked at, staff's feelings about evidence-based care, we found that sort of older, um, more experienced staff were more sort of open to it. Um, what we also found was that when we actually tried to put it into practice, they had a lot of resistance. And I think mainly because, as an older clinician, you're not used to being de-skilled. You're not used to not knowing something and to having to learn it again. And so we were asking them to put themselves in that position, and that was a bit of a challenge for them. Therapists who tended to be more anxious had more difficulty with it, and then certain sites also. But we just, the training department really sort of held the staff, held the sites, went in and did a lot of training, and also had a hotline to sort of help with certain sites that were struggling and feeling like patients weren't responding well, and gave a lot of feedback and coaching. And we really did welcome criticism. We set up opportunities for staff to, talk about what they were concerned about, and go through all the catastrophic fears that they had about what would happen. And what we kept asking them to do was to try it, to do it, just that kind of Nike, just do it. And that was one of the things that I think could allow this to happen, which was that it wasn't a choice. It wasn't that we said, if you like it, give it a try. Across our organization, the expectation was that we were doing this. Now, the good, the bad, the ugly of it, we're still going to be doing it. And I think there were a few therapists who left our organization because of that, but the majority of them stayed and leaned in and did it. And that really was the most effective thing. That over time, when they did use the manual, try it, they found that it was effective, and they found that it was more flexible than they had anticipated. Some of them actually became our expert champions over time, that they really felt like it was helpful to them.
Oh, did I cut you off, Gayle?
Yeah, no, I was done.
Oh, okay. So think about this as more of a collage than necessarily intended for you to read every word of it. We wanted to sprinkle in some attention to some of the more traditional, I guess, scholarly outputs from the work, because it took about 5 years before we published our first peer review manuscript on the project. And at that stage, you see a few examples here. It was a mix of more conceptual review papers, sort of describing this as more of a case study and implementation, including a paper that was published in the Argentine Journal of Clinical Psychology as part of that special series that many SPR members were involved in. So in addition to some of those more conceptual review papers, we also conducted a couple of qualitative studies that were published. One that was focused on clinicians, and then one that was focused on patients. So to spend a second on one of these in particular, a doctoral student at the time in my lab, Jennifer Oswald, conducted a qualitative study investigating clinician experiences, learning and implementing the new treatment, and did a series of semi-structured interviews, adopted a blended consensual qualitative research and grounded theory methodology. And just among the results found in the paper, I won't go through each of these things exhaustively, but actually found that clinicians reported appreciating having a bit more structure in terms of things that could guide the work in the groups that they were running. So they appreciated having a more explicit and cohesive treatment model. They also appreciated and encouraged continued leadership engagement and transparency about the process. So just be involved, be very clear about what it is. This is what we're doing. This is why we're doing it. This is how we envision accomplishing it. They also remarked on how they were interested in continuing to get more training, how it was important to keep in mind that we needed to maintain some flexibility within this expectation that they're going to follow this model within a certain structure. And so overall, I would say with this particular paper and some of this early work that's starting to get disseminated at this time, that I think it's a useful representation of practice-oriented research because the results from the interviews did directly inform the ongoing implementation work, but then they were also published to a wider audience. Yep.
So in terms of the full implementation process, and this is where I learned that it is a multi-year, ongoing, never-stopping process. There were certain things that we had to put in place just to, sort of keep things moving in the right direction. Part of it was having a very robust onboarding basic training for all new staff, because new staff are happening every month. And so we needed to develop something that could be put in place and that didn't require the training department training everybody each time they came in. So we made some virtual and recorded trainings that all new staff do. And they do about 8 hours of training before they start with the model. We also know that we have to keep doing refreshers and more advanced focuses on the various aspects of the model. So every year we, about every other month, we'll take one of the modules and really present it to staff and have them dialogue around it. And what we see over time is that they are dealing with it on a much deeper level than sort of where we started. And we see that as a very positive thing. I will tell you, a lot of the noise is out of the system now. I'm not getting calls of, oh my God, what's going to happen? I hate this model. We don't get that anymore. It is what we do, and people are quite happy with it. And we needed to have UT consistent programming throughout. So how we deal with nutrition is based in UT UP principles. How we deal with families is based, we want it all integrating in so that all of it makes sense to staff going forward and to our patients. And we continue to deal with, if somebody's having a hard time with it, addressing it with them and helping them to sort of grow in that way. And we're continuing to evolve our treatment model, our treatment manuals. One of the big changes we made, which we call UP 2.0, was to infuse much more culturally sensitive and competent language into our manuals. And this has been really, really important. And there are other areas that we are also evolving the model to address these things. And a big piece of what we do is supervision of our supervisors. We know that if our supervisors are not really skilled in what they're doing, and our supervisors are required to also do the treatment so that they don't just talk about it, but know it, they are in weekly supervision with the training department to keep their skills up to competency as well. And our staff continues to record their groups, and the supervisors then score it for fidelity and competence.
Okay, thanks, Gayle. So after all the work just described, we're still only kind of getting into like 2018, 2019, roughly in the timeline. That we judged at a certain point that we had a critical mass of what we would call post-implementation cases to compare in a design with the pre-implementation cohort. And so we published this analysis in Psychotherapy Research. As with any naturalistic data set, we had to make some a priori decisions about who would be included in the analysis. But the primary analysis included a total of 616 routinely presenting patients. 331 were treated prior to the implementation of the new program. 285 were treated after the implementation. And each participant completed a series of self-report measures at program admission, discharge, and 6-month follow-up. So as you can see, there are a good number of people here who were lost to follow-up. I will note that, again, this is not a big funded NIH trial. This is naturalistic research, like put it together, pick yourself up by your bootstraps, and so, I would say that, with over 100 participants, well over 100 participants in each group, it's still not bad. And I will also say that Renfrew works also very hard to keep their retention and follow-up rates up high, and they've gotten better over the years. But I'll also add that we conducted a missing data analysis, including pattern mixture models, and we didn't find any systematic influence of missingness on the outcomes. So there's a lot in this table, but I'll just kind of jump to the highlights. And this is, one snapshot of the overall results reported in the paper. But so as I mentioned, patients both pre and post, in order to do the comparison, that was required. We had individuals complete the EDEQ at the various time points for eating disorder severity, a brief depression symptom scale, an experiential avoidance measure, a mindfulness scale, and anxiety sensitivity index scale. And so first we looked at, and you'll see here in the table, we looked at effect size differences between admission and discharge, and then between admission and 6-month follow-up. And so we observed pretty much across the board, medium to large effects representing improvement across each of the measures in the post-implementation group. And most of those observed effects were larger in post-implementation group relative to the pre-implementation group. This pattern was more pronounced in the 6-month follow-up comparisons, in particular for eating disorder symptoms, depression, and mindfulness. And then the check marks over in the wide initial column relate to our intent to treat multi-level model analysis. So we actually looked at the trajectory of change across the groups, across these different measures. And we did find significant time by group interactions that favored the post-implementation group for changes in eating disorder symptoms, depression symptoms, and experiential avoidance. We had a lot of other evidence, including like the direction of the model of results, showing that there was also probably a slight favor for the post-implementation group in anxiety sensitivity, but the interaction effect in the model wasn't technically statistically significant. But we didn't find an effect or a significant interaction looking at the mindfulness outcome. So overall, this initial cohort analysis generated what we thought was pretty encouraging results, showing that at the very least, outcomes weren't getting worse. If anything, they were getting better, and they seemed to be across the board, at least slightly, in some cases, to a moderate degree, more positive than the pre-implementation phase. Yeah.
Okay, so sustainability, which is sort of where we are at this point, is that we really are continuing to focus on fidelity, competency and fidelity. We are looking at differences across sites. We do a quarterly research report where we are analyzing patient outcomes and really sort of comparing them across our organization. And we've identified certain sites, we call them our TLC sites. They need some tender loving care to really be able to sort of stay on track. And we sort of deploy the training department in particular to those sites to help get them where they need to be, both in terms of training needs that they may have, or just even data collection needs, that some sites are struggle a little bit more with data collection than others. We also are very much open to incorporating creative ideas. Our clinicians who work with the model day in and day out come up with some very, I think, unique ways of sort of presenting some of the data, or presenting some of the interventions with patients, engaging in patients around things. We've set up a system to not have it be hodgepodge, that everybody who thinks of something does it. It does have to get channeled through the training department to make sure that it's consistent with the model and that it is actually, going to be helpful. But clinicians really like the idea that they can submit some of their own ideas to this. We present our outcome data to our clinicians and to our other practitioners. And this really gets them motivated. I think when they see the patient outcomes, when we look at some of the comparison data, as treatment as usual, it really does increase their enthusiasm about the model. And we started to implement routine outcome measures, which I'll have James talk a little bit about. But that's also been an important part of our sustainability.
Okay, so more tables, more data. So we're in the sustainability phase, and so we're fast forwarding a few years from the results I just showed you. And we published a follow-up cohort analysis for a special series in Frontiers with 3 additional years of outcome data. And so just to kind of cut to the chase with the table is that we more or less replicated the results from the 2018 paper. So we looked at longitudinal outcomes that pretty much across the board showed that the post-implementation outcomes were better than the pre-implementation outcomes, with one difference, which is an eating disorder treatment center. So the one difference was that unlike 2018, we actually didn't find a significant interaction predicting longitudinal outcomes in eating disorder severity. But importantly, that needed to be contextualized because we did find a significant interaction with baseline or admission experiential avoidance levels. So patients who entered treatment with higher levels of experiential avoidance actually improved more in their eating disorder symptoms in the post-implementation cohort than the pre-implementation cohort. So again, we found overall differences that favored post-implementation treatment program on emotion functioning outcomes in particular. And then we also have that patient factor that further contextualizes things. The other thing to note is that we didn't really find any evidence of diminishing outcomes over the 5-year time span of data collection. And that's important because if you look at a lot of the published implementation research, especially in mental health, that you tend to find effects being watered down or diminished the longer you get out of the acute implementation phase. And so Renfrew's been able to maintain their outcomes over the course of time, which I think is pretty impressive. So Gayle also mentioned routine outcome monitoring. So I want to talk a little bit about measurement-based care, routine outcome monitoring. Clearly within their system, they worked really hard to develop an infrastructure for data collection. We had a pretty robust admission, discharge, 6-month follow-up assessment that allowed for things like this program evaluation, these cohort analyses. But it was recognized pretty early on in the process that sort of level of data collection wouldn't be sufficient if the ultimate goal was to collect information that could be used to support within treatment decision-making or more patient-centered decision-making. And so similar to the initial decision to adopt a treatment like the unified protocol, the team started thinking about how do we integrate the best practices in relation to measurement-based care. And this was complicated, as you might imagine, just because given the nature of the setting, given the nature of the population, trying to think about what do we want to measure? Are there any measures out there that actually will capture these things? Because obviously there still are and there were evidence-based outcome monitoring systems available, but most had been developed for and were used in routine outpatient settings in a more general psychiatric population, not specialized for eating disorders. There had even been a couple of studies where they used these more general measures for feedback studies in eating disorder contexts, and they were finding null results or in some cases negative results. And so considering that, and also if you can look at the standard eating disorder symptom measures, a lot of them are out there. We use them like the EDEQ, but they're really focused, not surprisingly, on eating disorder behaviors that are kind of artificially constrained within a controlled treatment setting like a residential site. So if I'm somebody who restricts a lot by running on the treadmill 5 hours a day, when you're in the residential treatment program, you don't have access to a treadmill, you can't restrict. And so we were also like, what are the relevant things that we would expect to change in an intensive treatment program? And so we ultimately decided that actually what we would need to do is design our own monitoring system, is to sort of come up with a tool that was appropriate for inpatient tracking on a day-to-day or week-to-week basis that would actually get at the eating disorder relevant behaviors within an inpatient setting. But then also because we wanted to maximize the clinical relevance of the information, we didn't want to just focus on like behaviors and symptoms necessarily. We also wanted to focus on change processes that are connected to the model, because if we're noticing that those things aren't changing, we actually do have a direct route then to shift what they're doing within the treatment program to meet that patient where they're at. And so that's what we did. While this was all going on, we embarked on a long-term project to develop and validate our own measure. It ended up with this published measure called the Progress Monitoring Tool for Eating Disorders, or PMED. And so we had 26 items with 5 subscales, tapping things like emotion avoidance, shape and weight concerns, eating disorder urges, behavioral urges, adaptive coping, and then relational connection to keep that historical relationship piece in there too, in addition to all the work that people are familiar with on the alliance and group cohesion, et cetera. So we wanted to make sure that we had that type of process skill in there too. And so once that was validated, then now we've spent the last few years really trying to crack crack the problem of like, how do we maximize the use of this tool to really kind of realize the definition of measurement-based care? How do we actually take that information and translate it into actionable information to help the patients? So, not surprisingly, because we can't help ourselves, this has turned into its own research project. And so I wonder, Gayle, if you want to say a couple of words about this Taylor's paper.
Yes. Well, one of the things that we were finding is that we rolled out the ROM a few years ago now, and there was really kind of inconsistent use of it. Some sites would be routinely having their patients fill out the ROM, and then the expectation was, the protocol that we had was that the therapist would get the scores. They were supposed to go over them with the patient, and then write a progress note about that and look at how they were going to integrate it into their treatment plan. But we found that there was a lot of variation across the organization, and clinicians were basically saying, I have no time, we can't do it, it's just too much. And so we felt like we needed to do a couple of things. One was to retrain individuals on how to use it so that it could be valuable to them. And secondly, we needed to look at the process itself and how we can make it less burdensome to them so that it would be something that would be incorporated within their clinical work. We did both of those things. We then retrained our staff to see if we could increase the improvements that we were seeing with the use of the ROM.
The results look pretty good.
Yeah, and her work showing that the training really did make a difference, and I think some of the things that we put into place really made a difference as well.
Yeah, including patients' own self-report about, like,
Yeah.
Yes, my clinician has talked to me about the feedback. Seeing those numbers go up is interesting to see.
Yeah, I mean, we had some sites where the patients were saying, what's that? I've never seen it before, and other sites where they were saying, yes, we use it all the time. So yeah.
Oh, yeah. So I'm mindful of the time, but here's another one of these collages. I mean, I think I just want to emphasize that as we're doing this work, which is focused on the clinical piece, like it is a clinically oriented project first and foremost, but we're also continuing to do more work to publish and disseminate the work that we're doing. And with the PMED in particular, with more intensive assessment, it really opens up the door for us to do more interesting process outcome research. So actually look more intensively at longitudinal outcomes and mechanisms of change. We've done some more research looking at the psychometric properties of the PMED. We've conducted other studies looking at patient level predictors and moderators of outcome, as the data set continues to accumulate. We've also done some kind of side studies, looking more carefully, including some experimental design work with single cases, trying to further refine and learn more about components of the treatment program that could be relevant for training. And so it's just a way to show that we're trying to get the word out as we're tackling these problems day to day.
And we did, all of this project did result in us publishing 2 books with, treatment that works through Wiley. We were getting a lot of feedback from clinicians in the field when we would be stepping patients down back into their practices, wondering, can we get some information on this to sort of help continue with the work that the patients were doing in the higher levels of care. And so we did publish these and have been just very, very pleased with the feedback that we've gotten from it. And to virtual. Yes, I'll talk about that as well. I mentioned that 2 years ago, we started with virtual care. And actually, you have to go back to 2020, I guess, when COVID hit. We had to move into virtual care within a weekend, basically. But fortunately, because of the model that we have and the fact that it is standardized and manualized, we were able to pretty easily move into a virtual platform with it and not miss a beat and know that the treatment was going to be consistent across the sites and whatnot. So we did do a study on that as well to look at, patient outcomes for, between virtual care and in-person care, that we were able to sort of compare those two things, and found, fortunately, that there wasn't much difference, that patient outcomes were, just as robust in the virtual care as in the in-person. And what was surprising to us is that it was so acceptable for patients that they did not find it unpleasant to be sort of in treatment all day on a computer. And so they were engaged and doing well with the model.
Yeah, and I just want to emphasize just that, as we all went through it, everybody's scrambling with the pandemic to adjust to remote work. And, if we could find a bit of evidence to support doing things a particular way, then that was great. But there was just a lot that we were just doing our best, and, I think it's important that we don't forget too, that for more complex settings, and especially inpatient settings, there just isn't a lot of evidence to draw from. As we kind of talk about the integration of external evidence, sometimes you have to create your own evidence. And so, at the time, if there were any virtual partial hospital programs for severe eating disorders before 2020, I'm going to guess that they weren't collecting a lot of data on their outcomes. And so, Renfrew, on the other hand, has been doing all this work up to that point, building that infrastructure. They were able to take the treatment and then shift into the virtual space, continue to collect data. And so in a relatively quick amount of time, actually look at their outcomes and then publish them. And so that's a pretty novel contribution to the eating disorder world that they were uniquely situated to do. And so again, I'm biased, but I think that's pretty impressive. So I'm going to steal my own thunder here for sake of time, because we're running out of time. And so I won't go through each of these criteria. I think it should be pretty obvious at this point that the work that's been done so far, whether fully intentional at all times or not, that the Renfrew Center seems to meet the criteria for a learning health system. So we'll say a little bit about lessons learned. And again, I'll try to give you the briefer version of this, is that, rather than repeat some of the things that we've already talked about, kind of touch on a couple of high level things. One is that I really do think that implementation science frameworks and principles in that research, it's more than just a new jargon or acronyms for us to learn. That having that as a framework really was critical to guide the decisions that we were making and anticipate things and come up with an evaluation plan that was actually going to give us useful information to know about, like, let's keep going in this direction, let's shift gears and do something else, so that we didn't run into the problems that some other implementation and training projects had. And so I guess that's just one general lesson learned, is that if you're not familiar with some of that work and you're doing anything like this, you should give it a look and sort of learn how it could be useful for you. The other thing that maybe is obvious is that there really was a lot of behind the scenes, at least from my perspective, behind the scenes work. I know Gayle was involved in it, but to build the basic structures, to come up with the structure for ongoing training and consultation, IT work, and even thinking about, like, how do you get the fidelity raters a recording from a group that just happened, but do it in a secure way. So sharing that information, in order to do this at scale and in an ongoing basis, you just have to have these basic structures. I think the other lesson is that this is an ongoing collaboration. It's not even really a marathon. It's more like an ultra marathon, or a marathon that doesn't stop, if that makes sense. I think, just jumping to the last point here too, is that I think it's important across the board to try to maintain a collaborative spirit. I think that might be a little less tangible than some of the other things that we've talked about. But again, speaking from my perspective as a researcher, or as in the consultant role in various points, is that it was always the clinical piece comes first. It's like what can we do to support better patient care? What can we do to support clinicians and staff to provide better care? That the first thing on your mind isn't like, when are we going to publish this? When are we going to get a grant submission in? Like, not that those things are unimportant. If you're an academic, obviously you need to think about those things, but if those things start to supersede the clinical effort or the clinical focus, then you're probably not in for the long run. So Gayle, do you want to take future directions as we wrap up?
Well, yes. I mean, I think I mentioned very early on that patient complexity, we're seeing much, much more of that. We're dealing a lot with neurodiversity and, just so many different issues that are coming. Our patients are coming in, I think, more psychiatrically ill as well as physically ill. And so we have to look at how do we evolve the model to be able to address that better. Um, and so, yeah, big data problem. You're going to talk about the big data problem?
Yeah, I'll just say that we are having a big data problem.
Okay.
We're collecting a lot of data, which is good, but looking at your outcomes or publishing it once every couple of years, there's a lot more that we could be doing with it. And so, trying to come up with a more efficient way of handling the information, and as I mentioned before, a more efficient way of translating some of the routine outcome data into more actionable strategies, that's a problem that we're working on, because we don't want to just, you sort of, everybody's busy, you look around and a year later and you have all this data that's just kind of gathering dust in a cloud. And so, really trying to think carefully about our use of the information and how to make use of it in a timely way I guess it's a good problem to have, but it is a problem.
Yeah. And in terms of just the rolling case for virtual treatments, there's a lot of movement in the eating disorder field right now with virtual care. And there's a tension somewhat between insurance providers and those doing virtual care, that insurance providers often want to say that there's no proof that it works. And we're putting out actually papers that indicate that it is in fact as effective. And then the last thing is just staff turnover, which has been more of an issue even now, I think, just in terms of our whole field and being able to, there's a lot of movement of staff. And so kind of keeping them competent has been a bit of a challenge.
It never ends.
Never ends.
So thank everybody.
Yeah.
Thank you for listening. I mean, I don't know, we're running out of time, but maybe we have a little bit of time for Q&A, and I'll just say, coming from, again, more the academic side, that I just want to say thanks and acknowledge all of particularly the doctoral students who've been involved in this collaboration over the years at UAlbany, at Drexel, at Miami. I'm probably missing certain places that just how important they've been to this entire process. And then also just how grateful I am to Gayle and her colleagues in Redford Center for, talking to Dave Barlow and getting pulled into this collaboration. It's been, I always tell Gayle that this is that's why we're talking about this today. It's like, this is the most meaningful thing I've done, as an academic who's interested in practice-oriented research. And so it's really been an honor to be involved in this collaboration.
Well, I can similarly, say that from my end as well, James, that if it wasn't for really the kind of relationship that we had with, with you all as researchers, you and Heather, and, and also the other labs that we have worked with, we would not be making the kind of progress that we did. And it truly takes a village. There's been a lot here at Renfrew from our owner. I mean, I only had one person I had to really sell on this, and Sam Minigat said yes, and it was willing to put the resources into it and continue to do so, that it's really made a difference. So appreciate all of that.
Thank you. Right on time in some ways.
No questions, but right on time.
Thank you so very much for an incredibly fascinating presentation on such important and truly inspiring work. And I think we might have time for like a couple of questions. So please feel free to ask, write in the chat, raise your hand.
Well, I'm gonna take the first stab at it. Firstly, I want to acknowledge all the work and the effort that you put into this. At the beginning, Gayle, you said that implementing evidence-based treatments, it's not easy. And that definitely came across. And how also, I think it's admirable how you took the call to action in a positive manner and not in a threatening or even with what you said also about the natural pull to treatment as usual and to resist changing. So I'm really curious as to what was your mindset behind that, how it was that you found yourself in that role trying to implement this huge line of work, and that I think you very successfully done so. But and also I think based on previous experiences, I found that perhaps some of the resistance to implement this is the fear of that, hey, perhaps what we're doing is not working, and the fear of showing that to people. So how do you balance that in the whole equation?
Yeah, yeah. No, well, thank you very much. And you're right. It was daunting. I think what really made the difference was that at the very beginning, I was empowered to be able to do it. You know, I was not fighting the system. And I think if I were fighting the system, it might have gotten too exhausting to do. But being able to really manage the uproar with staff and patients, that to me was doable. You just sort of ride the wave and sort of help them with it. But once I convinced the higher, our president and whatnot, he had concerns like, was this going to like make our profits go down? And probably if it had made a big difference, I might have been fighting that. But I think once we got over that, it allowed me to be able then to have more of an impact across the whole organization in a significant way. And I think also being, when James and Heather, and David could tell me things that made sense, that it was going to make a difference, like using routine outcome measures. I didn't really know that much about that. But when Heather shared the data with me that, actually the research shows that just even showing patients their progress makes a difference, even if you don't do anything particular with it, but show them. And it's like going, well, that makes sense. So yes, it really, having that kind of relationship really made a big difference.
I think it also helped because other people involved, but certainly Heather and I both being integrative in the way that we think about things in some ways, like coming from a CBT lab, trying to implement a broadly CBT treatment, but a treatment for the reasons that you kind of laid out, Gayle. Like there are a lot of things that would resonate with a dynamic clinician or a more experientially oriented humanistic clinician, and so we were able to kind of cross translate, for clinicians who were maybe less inclined towards CBT, to see like, I mean, this is kind of what we're labeling things. This is how it's kind of done by the book, but you could also think about it this way, or use this term instead. It's the same thing. Like these sorts of conversations, I think helped decrease maybe some of the resistance for some folks. Like the art therapy piece was a little bit difficult because that's even like, we're talking about different psychotherapy systems versus just in some ways different modalities. Like that was a tougher sell in some ways, but non-CBT clinicians, there were ways to have a conversation.
Particularly impressive for me was how it's integrated in so many dimensions. And for example, having stages of care from like intensive in-house care and outpatient care, and the many stages between. And as Gayle, you said, patients go back and forth in that scale. And I can't think of any institution, public or private, in Finland or that I've ever heard of, that has that that encompasses the whole scale.
Mm-hmm.
And that's something. It's so wise. And then I'm just agog at why doesn't everybody do it that way? But you have to have scale to be able to do that. And that's one thing that you guys had in your favor that not many places have. So you would have to have on a municipal scale or some real massive scale to be able to do that. But your thinking and your implementation in this respect as well was impressive. Thank you.
Thank you.
Thanks. Yeah, I mean, Gayle deserves the credit for all of that, but I think it also makes me think about because there's so much, people go in and out of different higher levels of care, needing to have a cohesive program, across those different levels and those different contexts and the different sites across the country, even including more locally, like you were talking about nutrition. I mean, one thing that we've talked about, that this is the one paper that we didn't think to look at this more systematically. And so it's somewhat based on anecdote, but these are the people delivering the treatment, is that we weren't able to publish the medication prescribers telling us that there was a huge drop in their use of as needed anxiety medication in the setting, that they used to prescribe a lot of anti-anxiety medication. And again, as part of the model, like, we're not saying that you can't do that. We're just saying that if the patients are zoned out, for lack of a better term, in the groups, because they're being overly medicated, let's just say, then they're probably not going to get a lot out of it. And then there's even a lot of evidence, right, in exposure therapy for other types of problems that those sorts of medications can undermine extinction, and so they were eventually, right, they got on board. And I think they were saying it was like at least the 50% or something drop in their anti-anxiety medication prescriptions. And you could see the outcomes are pretty good. Like, the outcomes didn't get worse. And so that is the one paper that I'm like, how did we not think about looking at that more systematically? Because I think it's a pretty wild finding.
Well, I think it's what has helped with the buy-in. And you're right, psychiatry was one of them. We used to have routinely, patients would stop at the med window before the meal to get their, anti-anxiety medication before they'd go in, their benzo or what. And we just stopped that practice. And I think then when the psychiatrist could actually use UP-based language with patients and help them to understand why it is they're not, necessarily having them on this medication, and giving them tools, it actually reduced all of that. And the fears were that patients were just going to freak out and leave, and that just hasn't happened.
A lot of social learning is state dependent. So if you learn how to manage a difficult situation in a chemicalized state, it will not automatically be transferred. That learning will not automatically be transferred to a non-medicated state. So, so actually, reduction in medication could be an outcome measure in itself.
Yep. Yep.
With predictive effect.
Yeah.
Ooh.
Okay, thank you everyone so much. Again, I will just mention that the webinar has been recorded, and that the recording will be available on our YouTube channel and the SPR webinar webpage. Thank you for being here, and thank you for sharing your amazing work. And,
Thank you.
See you all
Very
next
nice.
time.
Uh-huh.
It's a pleasure. Bye-bye.
Bye-bye.